else before we move on?
Yeah, I was just going to say, maybe we should move into the care now that we had a lot of questions regarding care of SEPN1. We could move into that section of things.
Great, that would be wonderful. So why don't we have the 4 panelists come sit up here so we can really have everybody up there at the same time and hopefully have this as interactive as possible. I'll let you introduce.
Sure. And what I will do is have all of the panelists introduce themselves, because I don't know all of your history or pertinent information to share. But we have a panel here that we get to ask those questions about SEPN1 care. So I'll pass them. Oh, we have wired microphones up here.
See how it works.
You want us to use the yellow one?
Yellow's working. So I introduced myself as a pulmonologist, but I also work with our orthopedic surgeons managing children with scoliosis. I do more of the assessment and we work together. So while I can't comment specifically on SEPN1 from vast experience, and I suspect that would be the case for many people, I can talk conceptually about scoliosis management, chest wall management, and some of the issues that are involved in determining how to go forward.
All right, I'm Dr. Steven Chavez. I have a PhD in nutrition. I'm also a registered dietitian. I'm here representing Children's National Medical Center, so I work in pediatrics. I privately consult with Georgetown University Health Systems, so I work with adult patients as well, also in a clinical setting.
I'm Goknur, Haliloglu. I do work in Ankara, Hacettepe University Children's Hospital. I'm a pediatric neurologist. I'm a clinician, basically seeing patients and coming from a really different health system. I have to say that I really appreciate all of the efforts that you put in, because usually the associations in Turkey covers DMD and spinal muscular atrophy patients. I really appreciate your all input divided into separate subgroups within even the same disease process. So it has really been a very great opportunity for me to be both in the scientific and the family sessions. We do care for patients in the clinic, and from time to time we have some challenges as pediatric neurologists. Those were really covered yesterday, especially in the respiratory nutrition panels. Sometimes the intensive care unit physicians and pulmonologists in our center do not agree on the same patients, so that is really a very huge problem when you just look at your patient from a pediatric neurology perspective. So you just try to bring everyone to be on the same page. So that really requires an extra effort in my setting, at least. I don't know how things are going here, but the acute care and the chronic care really differs, and we have to stress that there must be people educated, especially not only in the pulmonology field, but specifically in the pulmonology field, covering the pediatric neuromuscular diseases as a separate thing in their education program as well. So I have to say that at first, yeah.
Great, I'm John Day. I run the neuromuscular program at Stanford. I'm an adult trained, but they let me play with the kids too, so I get to see children and adults with SEPN1 or SELENON, as I'm trying to learn how to say it. So I've seen several patients over the years from Minnesota when I used to be at the University of Minnesota, and now in California we're seeing more patients with SELENON and working with them. I think the role of a neurologist in the clinic is evolving, I'm happy to say. It always used to be focused on diagnosis. We felt so proud of ourselves when we could tell you what you had. But that's obviously not enough. We have to be there and fight for you and fight with you to kind of help mitigate the challenges. And I think the role of the neurologist ends up being almost that of a primary care physician, So we're primary care physicians for a very tiny subset of the population because, we do try to help with all elements of what's going on with patients that have this. So we work very, very closely with the pulmonologists, since that's a big issue for SELENON, but also with the orthopedists, with gastroenterologists, with a number of different subspecialties, and always focusing on the muscle. So we're always interested in trying to come up with new ways to make the muscle work better and to help. And so then we're working with our kind of pseudo-clinicians like Dr. Beggs. He'll always tell you he's not a clinician, but he has much more clinical experience in this condition than almost anybody else. So we do listen to what he says, and Dr. Ferrero and others who really have a lot of experience. So I think that puts us in this role of being kind of betwixt and between and trying to integrate things for the patient. So should we just open it up for questions, or how do you want to handle this?
That'd be great. Yeah, I think there are a lot of questions in the room, I'm guessing. So that'd be great if we could open it up now.
Or we could start asking you guys questions, because we always learn from you. So.
I actually have two questions. So I'm going to ask, the first is for someone who's not here, and she asked me to ask if anyone in here has experienced migraines, or if we've seen migraines in SEPN1 patients. Her son is, I think it's the 11-year-old, is experiencing migraines, and they're in the afternoon to the point of, like, they're pretty significant. So she wasn't sure if it was a SEPN1 related, or if it's something completely different, or if you could experience migraines if your BiPAP settings are not tweaked right, or is that something she should assume?
So I'm not really aware of a link between, if we just back up and say, when we say the BiPAP or ventilator settings need to be adjusted, that would presumably be because of high CO2, hypercarbia. That's something that can cause morning headaches. If you have high CO2, the vessels in the brain will dilate so that it helps the brain get rid of carbon dioxide. That's typically a very transient phenomenon, and what will typically happen, especially in patients before they're on nighttime ventilation, is that they'll complain of morning headaches. And then when they get up and dress, shower, get breakfast, those typically go away fairly quickly as you normalize your carbon dioxide. I don't know enough about migraines, and I'll turn things over to my neurology colleagues, but I don't know whether hypercapnia or maybe mild hypoxemia could trigger a migraine attack. That would be the only mechanism I can think of.
So far, I have seen more than, I believe, 15 to 20 patients with SELENON-related myopathy. I don't recall any patient coming to my clinic with a migraine, with a complaint of migraine. So if there is not related to any pulmonary issue like nocturnal hypoventilation, or that must be elegantly managed separately.
I don't have anything additional really to add. Migraines are very, very common in the general population, and so that establishing a cause and effect relationship is difficult. But I would never say never, and I think that it's quite interesting to posit that, because we do know that migraine does associate with other conditions that are related to oxidative stress and other things. So I think it's an interesting postulate, but I have no real information on it.
And I actually had one other question, follow-up from yesterday morning when you were talking about at the pulmonary, if you need oxygen seconds or minutes, basically. So, for example, this year my son, he had kind of a stomach flu type of bug and was doing okay, but then we went in because it was lasting too long. And just in that, and within a couple hours, so I called in the morning and we went in at 1, by the time we got to the clinic, I was like, this isn't looking good. By the time we got into the room, his oxygen was probably down, I want to say it was at like 78. And so immediately his doctor's like, he needs oxygen. And I knew, well, we can't just be on oxygen, we need other stuff. But is there a difference if, like he's sitting, I wasn't quite sure what to do. I knew it was going to be short term. It wasn't minutes, it was, you know, he had to take the ambulance from the clinic to the hospital settings. He was on oxygen the whole time. I was insistent that at least he's sitting up because I knew the supine would be worse. But what should I have done differently? Do they have ventilators equipped in the ambulance for the ride? I was kind of at this, well, I know 78 isn't good and he's not looking good and the oxygen is going to help, but.
So your son is not on ventilation?
No, he has a BiPAP.
Oh, he has BiPAP. Okay. So let me clarify something. Oxygen is not bad, but it's bad if you're using it as the sole line of therapy. And what I would bounce back to you as parents is if your child had a fever, would you just keep giving them Tylenol or Motrin? The answer is no. You would say, well, why is my child having a fever? And you might take him to the pediatrician and see if perhaps he has an ear infection or if it's just a simple cold, but you'd get an answer. And that's really what the issue is. If you, for somebody without neuromuscular disease, if you go to the hospital, to the emergency room with a pneumonia, and you have low oxygen, it's probably because of your pneumonia. And it would be perfectly reasonable to start with some oxygen. In patients with neuromuscular disease, while you're trying to figure out why your low oxygen has occurred, you can use oxygen, but you still need to then answer the question whether that's getting a blood gas or doing some other measurement of carbon dioxide while you arrange to get a ventilator, whether it's your BiPAP, which maybe you strapped threw over your shoulder and brought into the emergency room, or the hospital getting a ventilator. You can use oxygen until you get ventilatory systems. And the other part of it that we talked about in the second half of the pulmonary meeting is typically if you have acute changes in oxygen, or carbon dioxide for that matter, that's almost certainly going to be from secretions from an acute illness. And so while managing oxygen and carbon dioxide is very, very important, it's also important to make the lungs work better, and that would be by aggressively using airway clearance. Something like the cough assist, which is sort of the primary modality, in addition to antibiotics, of course, and other ways of clearing mucus from the lungs.
Thank you.
Hi, I have a question about how to strengthen a diaphragm other than a cough assist. If there's anything new at all, new exercises or anything, or it might be a kind of a strange question, but my daughter is singing. She sings a lot, and it seems like her lung function has improved a little bit, and I don't know if you know anything about that.
I think there are two issues there. The more deeply you breathe, the more you stretch your rib cage, the more you re-expand your lungs. For those of us without neuromuscular disease, we wake up in the morning and we stretch and take a deep breath. That helps to open parts of your lung that you haven't used. And one of the things that happens in neuromuscular disease, whatever the source, is that as you progressively lose the ability to breathe in deeply, you also lose lung capacity, which then adds to the work that's needed to breathe. And so it's a concept called compliance, which is how stretchable or movable the lungs are and the muscles are. Compliance goes down as you lose muscle function. And so one of the things that many of us are interested in is using the cough assist, not just for airway clearance, but for doing deep breathing. It's not going to strengthen muscles per se, but it can help maintain flexibility, sort of like physical therapy. To specifically address your question about strengthening the diaphragm, there are established techniques to do inspiratory or expiratory muscle training with a little breathing device that has a spring-loaded valve that you can set to a portion of your maximum inspiratory pressure, which is a test that we do in the pulmonary function lab. One of the questions that I asked in the scientific conference to Anna is whether that would be safe to do in SEPN1. And one of the questions is, if you stress the muscle, are you damaging it? And when those of us who don't have neuromuscular disease exercise, part of the act of building muscle is stressing the muscle that you have, and then you regenerate or grow muscle to accommodate for the added stress. I think there have been some small papers, one in Duchenne and one in, I think, it's a mixed group of congenital muscular dystrophy patients, where they looked at pre-surgically doing inspiratory muscle training, and they did show a slight improvement in lung function. That went away, of course, when the inspiratory muscle training was stopped after surgery. So I think there's room to do something along the lines of inspiratory muscle training, but for me, I'd want to do it in conjunction with one of my neurology colleagues to make sure that we're helping and not hurting.
Follow-up question right here.
Yesterday, orange? It's orange. Thank you. Yesterday there was a question about the difference between cough assist and breath stacking and what their relative strengths and weaknesses are. Can you comment on that?
Sure. There's a big difference. Cough assist augments your ability to breathe in, which is what breath stacking does. And then, where you go? Over here. Right there.
Feedback from the speaker.
Oh, it's the speaker right there. That's a big one. And then, so breath stacking and a cough assist, you were able to breathe in deeply. And then the cough assist adds the benefit of an expiratory assistance, so suction essentially. So air is blown in, and then, okay, thank you. So with the cough assist, you get the benefit of a large breath, and then you cycle almost immediately to negative pressure to help remove the mucus. There's another modality similar to breath stacking called intermittent positive pressure breaths, which is just the inspiratory part of the cough assist. And then what happens is that after you take the breath in, the patient then exhales as fully as they possibly can. And for patients that have a stiff chest wall, if they're able to breathe up deeper than normal, the chest wall has low compliance or high elastance, meaning that it's very stiff. If you stretch it, then sometimes just the force of the chest wall settling back to its normal volume is enough to help make an effective expiratory effort, so to create a cough. But I think it's largely agreed upon that the cough assist is the primary, most effective mode of airway clearance, because you get both inspiratory and expiratory assistance.
What about for therapeutic?
For doing just deep breathing, you can do either breath stacking, IPPB, intermittent positive pressure breaths, or using the inspiratory part of the cough assist.
I have a question for Dr. Chavez. Our daughter supplements nutrition with a lot of beverages, pediatrics and so forth. Is that a long-term solution? She's doing it to gain weight. At this point, she's still barely on the positive growth chart for her height, because we're her parents, her height to weight. Is that a long-term solution? Are there other suggestions? Obviously, SEPN1 individuals are shorter stature, skinny individuals. There's also a little bit of dysphagia happening. Chewing seems to be hard. She fatigues with chewing. I would say the whole eating, nutrition experience kind of affects quality of life for her. So just kind of what feedback do you have on that aspect?
Okay, so if you listened yesterday to our talk on nutrition that we had, I think it was like 3 p.m. yesterday. We talked about a lot of those things. So one of the big ones is the growth chart is not always relevant for when we're looking at congenital muscular dystrophies. We're going to look at the height to weight ratio more so than we're going to look at where do you plot. We look at your growth over time. One point in time doesn't necessarily tell us the whole story. So we look as a child is growing to how they're developing. Secondly, I would say liquids are more beneficial because as you look at dysphagia and the effort it requires to chew, that can be very expensive from a fuel standpoint. So you can burn a lot of calories and get really fatigued, and then your meals can take an hour or more. And that's not good for quality of life. So I see patients typically with our speech pathologist, and we look at what is actually efficient eating. So typically a meal should be 30 minutes or less. A lot of times with congenital muscular dystrophies, it takes longer. So we want to be efficient in eating, but we also want to be safe. And typically when we look at solid foods, and if, again, steak is probably something that really shouldn't happen that much unless it's something that's really soft and easy to swallow. But what happens is you chew and chew and chew, and then by the end of the meal, basically you're getting really tired, and then you are not safely swallowing, and then you're more likely to aspirate. So liquids are more beneficial to an extent in that we can get similar calories in a little bit safer because you don't have to do all the chewing. So from a short term, yes, that works, but most of what we see is that it is a short term solution that does not last because you're not going to be getting all the calories you need. So usually this is when we go towards the G-tube placement for enteral feeds and then rely more on oral feeds for more pleasure-based. So that way we're getting most of the food going right into our stomach and bypassing this area just because we don't want to have any risk of aspiration pneumonia.
What's your definition of short term?
Typically, the sooner the better I go for G-tube, especially if it's taking more than 30 minutes to eat.
No,
So
when you said...
Right, the short-term fix.
Yeah.
So I do it more so until we see that growth is not increasing. So if we see stagnant growth on the growth chart and basically no weight gain, quality of life seems to be interfered because we have to start eating and then we take a short break and then we have to go back to it. And I think it comes down to the quality of life more so, that's where I say it's no longer beneficial to rely solely on liquids. And I think, so my short term varies for each person. Like I have patients that just do not want a G-tube and we're like, and every time we see them, we're like, this is your issue, this is your risk. If you're not getting the sufficient calories you need, especially from a protein standpoint, muscle will be sacrificed. That will make everything worse because that muscle's not coming back.
Orange. I just have a question. Oh, I'm sorry, you have more to say on that?
I was just going to play off of Steven's comments because I think it's really important. I think very few people are born wishing they had a G-tube. I mean, it really is fairly universal aversion to that. And I think, when we see people that are having issues, struggling to meet their caloric needs, their nutritional needs, we try to start that conversation fairly early to kind of lower the apprehension and concern. The technology of G-tubes has gotten so much better. It really is not as big an issue as it used to be. You know, I have to ask patients if they have them. I forget, you can't tell. I mean, you pull your shirt down, you don't know if there's a G-tube there. And you can still eat for pleasure. You can use it as much as you need it. And if you get a sore throat or something, you can still get your nutritional needs met at that time while you have the cold.
Are there known SEPN1 families that you guys have had or in the room with G-tubes?
I can't speak to in the room, but I certainly know individuals with them.
I have my daughter has a G-tube. We have MLD, so it's a different disease.
I'm asking about SEPN1 though.
Yes, I do know patients with SEPN1 with G-tubes.
This maybe really, once again, addresses the importance of natural history studies, as Ellen very nicely indicated. So we just, maybe my question will be, the growth chart for general population will not work for selenoprotein patients, so that must be also adjusted, and these natural history studies will really help to understand how to evaluate the growth.
Yeah, so our general growth charts are for the general population. The only one that I really know of is the Down syndrome has their own growth chart. And then I think there's kind of a modified Duchenne muscular dystrophy one as well. They're not highly ever publicized, but there are others based on natural history where we see typical gains and things on weight. And again, kind of going back to the whole G-tube thing, it doesn't always matter what the diagnosis is, it comes down to the safety of the swallow. If you have dysphagia, if you are not safe to swallow, we need another way to get nutrition in. So one person is not going to be the same as another because we see differences on how the diagnosis affects individuals, that if it is not safe for this child to swallow, we need to find a new way that is safe to make sure they can meet their needs. So just saying, do all SEPN1 get a G-tube? No. But are there going to be extremes that need it? Yes.
Orange here?
Is yours a follow-up?
Yeah. So with the G-tube, I know there's been a lot of talk in the Facebook group, back and forth, and I think we talked about it 2 summers ago, having the extra weight going on because of supplements and stuff like that made a lot of people nervous, and their doctors were saying, no, the small stature has a lot to do with how much your bodies can support, we don't want to, and the scoliosis. And there was a lot of kind of controversy in the online community about whether their bodies naturally were going to stay very light because they needed to be versus adding on additional weight with a G-tube or supplements that was causing additional problems.
So it's a happy balance. That's the easiest way to look at it. So I have a background in sports nutrition as well, so I know all methods of looking at body composition, and I really like to use our DEXA scans because we can actually get an idea of muscle mass to fat ratios.
What is the DEXA scan?
It's a dual energy X-ray absorptiometry. Usually we use it for bone health. So if you ever hear that someone has osteoporosis, they need to get a bone scan, that's what we're looking at. So it is also used for body composition, that we can actually look at your lean mass versus your fat mass. So we can see where the fat deposits are. So from a nutrition standpoint, if we would go into the technical side of things, we don't need to feed fat. We need to feed muscle, because muscle is what uses the fuel. So it gives us a better idea of how much you would actually need for caloric needs. So in combination with the G-tube, that's something I recommend. Again, if you have spinal fusions and things like that, we can still look at body composition. We have to look at bone density differently. So there are ways around it to have a better understanding of what fuel we need. It's a little bit easier in an adult population than it is in peds. But it is one of those that we have other techniques. I'm hoping to look at some of those, looking at resting metabolic rates and trying to get a better understanding of what our fuel needs are in the pediatric population that is affected, to have an idea of how many calories do you need. We use general numbers right now based on what we would expect. So again, there's lots of questions that go into this, and everyone is different with those regards. That having a better understanding of muscle mass gives us a better idea of how many calories we need based on lean body mass.
So do you have recommendations on how we should talk to our dietitians or nutritionists back at home to try and set up a better way of getting nutrition to our kids and ourselves?
I would always recommend doing a DEXA just to get an idea of body composition. They won't necessarily 100% know exactly how to go about that, but it'll give them a better idea that if we do a DEXA now, and we know based on athletes that you can technically do a DEXA scan every day. It is low radiation, but it's the same as if you went through like the TSA scans at the airport. So it's one of those you could technically do it every day, and we haven't seen any negative effects from that. So it's one of those, does insurance cover it? How frequently? That's our kind of question on how frequently can we do those from a clinical standpoint. But we're typically looking at them every 6 months to a year to kind of see how that changes. We're definitely looking at it with SMA based on Spinraza and how that's changed some of the muscle function. So there are ways that we can kind of understand that. So I would say getting an idea of body composition would definitely help your dietitian understand, okay, we're changing it, we're increasing the G-tube feeds now. Is that changing the body fat, or exactly how is it changing it? Like, are they getting taller, or are they just getting wider, as I like to say?
Thank you.
So I just have a follow-up question on the nutrition. So, like, the average diet has like 20% protein for average people. Would you recommend a higher or lower protein, like, percentage of your diet for people with SEP1 or other congenital muscular dystrophies?
So I don't pay attention to percentages of calories from what fuel. I kind of look at it in the end run, but I focus more on basic the needs are grams of protein per kilogram body weight. So I look at meeting those needs first, and then it kind of comes down to what percent of your calories is that. So making sure you're getting sufficient protein is the priority, and again, that's based on age. Yesterday I mentioned typically a newborn is going to be up towards 2 grams of protein per kilogram body weight, and that goes down to the recommendation for the adult population is 0.8 grams per kilogram body weight. As we get older, it seems like the recommendations are now starting to go up back to 1 gram per kilogram or 1.2 grams of protein per kilogram body weight. So as long as we're hitting those numbers, I'm happier than it's 20% or 15% of your total calories.
Thank you.
If I can ask a question on just a little bit different track from the consuming calories, but to using them. We have 2 boys, 9 and 12, and I was curious, what are the some of their daily activities? They don't necessarily jump really high or at all, and other than pursuing becoming an astronaut on the moon with less gravity where they could jump higher, they're not willing to go that route. But more specifically, one that they can handle perhaps is swimming. Can you talk a little bit about, or I'm curious, others' experience with this as well, with neck weakness? Swimming has been a real struggle for us. We live in Wisconsin, there's lots of lakes and rivers, and so I'm just curious what your experience has been in kids in the water, activities like that.
Yeah, we're big advocates. I'm sorry there's not a physical therapist on the panel as well. Physical therapy is really an integral part of our team. But we're very big on water-based activities, not necessarily swimming. I mean, swimming is fine if you can do it, but there are a lot of things you can do in the water. You know, even just walking in the water, and all kinds of muscle disease. One of the things we try to reduce is any kind of muscle trauma or muscle damage. And you get that with a particular kind of exercise, oftentimes eccentric contractions that are, if you're lifting a weight up, that's using concentric contraction of your biceps, it's shortening while you're lifting it, and as you're putting it back down, that's eccentric. The biceps is actually lengthening while you're controlling it going down. And that's harder on muscle in general. I'm speaking in very general terms. It's hard to not involve some element of eccentric exercise when you're working against gravity. And that's the glory of being in the water, is oftentimes your exercise doesn't have that gravitational component. So you can combine a lot of exercise without getting that muscle damage. So I think it's a great form of exercise. I think with all types of exercise, and this is really true for SEPN1, we really try to avoid any kind of exercise that's going to stress the muscle beyond its oxidative capabilities. So that we really don't want to exercise to the point of exhaustion. That's oftentimes when you're getting into trouble, and we think with the underlying mechanisms, we go back to N-acetylcysteine use and trying to maintain oxygen levels with pulmonary care and all of these things. We're trying to make sure we're not overstressing the muscle, and that's true in exercise as well.
If you're in the water, you have to be symmetric, so that really helps to balance your body as well. So for all muscle diseases in general, we just take the advantage of being in water, rather swimming or doing other activities as well. But the critical point is the pain and fatigue that really is something that must be defined individually. So that is an upper threshold, and I have to stress once again the balance between the exercise you are doing and the pain and fatigue that you have at the end. So you have to balance.
Just a follow-up question on the water. Can you hear me? As far as like holding their breath underwater, I know our son likes to do that. He seems to be able to hold his breath well. I think I've heard that with some other SEPN1 people that, I don't know. Anyway, so is that a good thing for him to take those big breaths and hold it, or is that maybe damaging and putting more stress?
I don't think it's damaging anything, but certainly the act of taking a deep breath is very helpful, because you're taking the deep breath and stretching your respiratory muscles and expanding your lungs.
Right here.
So I had a question about yesterday. We were talking about NAC, and I take oral albuterol, and I was wondering what you thought about that.
I mean, I'm interested in your response to it. I mean, we use oral albuterol in a number of neuromuscular disorders, and it's really hard for us to be confident always that it's having benefit or not. So I think it ends up being an individual issue. It can cause jitteriness, so some people don't like it just because of that. But there's a very interesting mechanism of albuterol in improving the signaling between nerves and muscles that we try to take advantage of that sometimes is helpful. So that albuterol, it's a very different situation than N-acetylcysteine. So we use it in different patients. I haven't actually tried it in patients with SELENON, so I'm curious about your response. But it's a different approach. It's a different issue. It's really for symptomatic management to give you more stamina generally, and if that works, then that's great. But it doesn't supplant the recommendation for N-acetylcysteine, which I really do try to get the patients with SELENON to take.
Going back to oxidative stress and pushing yourself to exhaustion, I've noticed that when taking NAC, some of the most effective times with it, I have pushed myself to exhaustion. Where I've done it, I feel like the only thing I can do is sit down and do nothing. And then I wait 10 minutes and I get up and I feel completely different. I'm not sure what your take on that is. Or I would feel better than I did before I started to exercise. Even though 10 minutes ago, all I would want to do is just lay down and do nothing.
So when you say you sit down and after 10 minutes you feel different in a good way? Or
Yes.
You said it's restorative.
Almost like a second wind.
Yeah. Well, I think that's a great observation. I think we're all learning. We don't have great ways of measuring the functional or clinical benefits of NAC, and I, so I'm using it partly because of, what patients tell me, in terms of their response, but also in terms of what Dr. Beggs and Dr. Ferraro are telling me that, it makes sense from a scientific endpoint. But I think that we're still looking for good measures clinically. Alan, do you want to make it?
Well, I don't have anything to add to this, but I see an opportunity here. That, the other day we talked about Anna's controlled trial, and then the fact that many people in this room are taking it on an ad hoc basis. And I wonder if we could get you guys together with Anna and anybody else, any other clinicians who have been using it, think about maybe some basic recommendations on dosage and timing and so on. And then also think about some very simple patient-related outcome measures. We call these PROs, PRO, patient-related outcomes. Basically, that just means things you can write down and tell us about.
Yeah,
and so
I agree.
Knowing what Griffin just said is very important. We might ask, how do you feel after recovery.
Yep.
And try to glean some useful information from this. This is one of the questions in the last half hour. You know, how can we come up with good general recommendations?
Sorry, just to clarify, when you say, so you, all right, do you take N-acetylcysteine regularly, and then like that this is something that happened, like, I'm trying to word this. So like, do you take it and then you sit down and then you feel better, like quickly, or is it like you take it regularly and then you have noticed this side effect or this effect over time?
Yeah, I take it regularly, maybe once a day, once every 2 days. I usually take it before I know I'm doing some sort of exercise or activity. Like, let's say if I knew I was gonna come over here, because we're staying at the Westin, I would take that, because I know it would be a good maybe half-mile walk. But yeah, anytime before I do exercise, I usually take things that I think it might make my exercises better. Yeah, so that's usually why I get exhausted, because I push myself a lot, and sometimes I push myself too much. But what I've noticed is sometimes when that happens, I'll sit down, rest for a second, I'll get back up, and I'll feel completely different.
That's what you're saying.
Can I get you to comment while you have the mic as to side effects that you've experienced with NAC?
Yeah, the main side effects, which I think I've more or less gotten used to, is every now and then a little bit nauseous right after I take it, but that usually passes within about 30 to 45 minutes. But I've also been taking it for a while now, so I think my body has just more or less gotten used to it. And I think that's about it. I think someone commented on how one of the studies, how if you take it at night, it does keep you up. And I think that is kind of from the perked up feeling where your brain kind of just wants to stay up. I've noticed that not only that sometimes there's not only a physical effect, but also a mental effect, which I don't think is a bad thing. Or sometimes I'll take it and my mind will clear up. It'll be super easy to focus as well. I'm not sure if that's usually after exercise, so I'm not sure if that's just like a post-workout clarity or whatever. That's also the NAC work kicking in. But nothing too bad has come out of it. I mean, maybe, as you said, chest tightness is one side effect. I've found that sometimes it's always been pretty mild, and it passes a little bit within a few minutes. So, yeah.
Thanks. I mean, you know, it's really safe. It's been used in a lot of different trials and a lot of different conditions. You know, it's still used at really high doses. People use it intravenously for, you know, acute toxicity and carbon monoxide poisonings and things like that. It's been tried in various neuromuscular disorders, and it never really showed that much of a benefit. But that comes back to this issue that I don't think we know what to measure. I don't think we know what to ask. So I think Alan's idea of getting kind of you guys to tell us, you know, what you're experiencing might give us some clues as to, you know, how we can best measure the benefits of this.
We've got about 10 minutes left, and then we've got a couple other questions here. Mike?
Okay, I'm just going to comment on the NAC. I found trying to keep a more constant level of the supplement in your body helps. Because if you take like a large dose once a day, I've noticed, you know, negative effects when it wears off. So constant dose is better. I do it twice a day, which seems okay. And then my other question, I've had a DEXA scan and it shows osteoporosis, but I'm a bit skeptical about it because my bones are pretty small compared to the general population. So do you guys have any guidelines on how to interpret bone density from a DEXA scan?
So I work directly with, we have a nurse practitioner from endocrinology with bone health in our clinic that I work with her a lot on kind of our recommendations. So really just looking at kind of your calcium and vitamin D levels, just because vitamin D is important for calcium reabsorption. So we want to make sure that we prevent you from losing extra calcium. So what's happening with osteoporosis is the calcium is leached out of the bone. Calcium is used for a lot of different functions, including intramuscular signaling and things like that. So we want to make sure you have the adequate nutrition you need to prevent that. But again, looking at that, it's how likely are you, if you were to fall, are you more likely to break a bone? And that's where we get concerned with the osteoporosis component. And because you're not jumping up and down and doing typical weight-bearing activities like we would make as recommendations for the general public, that's where we get concerned. So they are comparing it to the general population, but it is something that we do want to be cautious of, because if you were to trip and fall, you would probably have an increased likelihood of breaking a bone. And that's why, if you are getting that recommendation, we do want to really monitor your nutritional status to see if we can basically prevent any further deterioration of the bones basically breaking down.
I'm just questioning the accuracy of the test because it takes a 2D cross-section of the bone and kind of compares that to the general population to calculate a 3D density value. So if the bone is smaller, it distorts the significance of the value.
Yeah, I think that we had largely moved away from using the DEXA scan results for issues of bone health. I know in the Duchenne field there used to be a lot of emphasis on DEXA scans and then putting people on these oral bisphosphonates like Fosamax and stuff like that. The current guidelines for Duchenne are really not to focus on that you can use it, you can maybe see if there's changes, but not to use that necessarily as a reason for starting some of those aggressive medications. So I think just for the reasons you brought up, and also because it's oftentimes in the pediatric age range, we just don't know how to interpret those bone results specifically. So, we emphasize, vitamin D very much. I mean, checking vitamin D levels to see. I mean, I can tell you that even in California where you have all this sunshine, I mean, everybody is vitamin D deficient. I mean, essentially, we have to put almost everybody on supplemental vitamin D to make sure that they have enough. And then there are ways to look for smaller fractures. Certainly if you have non-traumatic fractures, then those are things. So we'll look in the spine and see if we're seeing any changes of vertebral collapse that would indicate that really the bone is getting too soft. And then we might start using some of these agents, oftentimes using intravenous treatments, to be honest with you, rather than the oral ones. But then the other thing is just using your bones. So we've talked about the glories of water-based exercise, and it's great for muscle. It's not so great for bone. So that for bones, we do want you to be really weight-bearing. We want you to really use it. And so how do you put that together? One of the ways is just by standing. So we emphasize the importance of standing. Even people who can't stand independently, we'll try to get them standing support so that they can stay in a standing position, because then you are getting that increase in pressure on your bones that helps them. There are studies that use these vibrating plates that people use. I don't think they've been well substantiated. It's certainly not widely agreed upon, just to put that out there. But I think standing, everybody can get behind.
I just have a quick question about sleep studies. We have a great pulmonologist, and she's also our sleep doctor. We were her first SEPN1 patient, and we really kind of blew her protocols out of the water. So how often should we be pushing for sleep studies, for titration?
I'm probably the wrong person to ask because I don't do sleep studies very often, but my general approach is, if you think back to when you started Dr. Steven Chavez, it was treating something that wasn't right. And most patients will be able to say, yeah, I feel a lot better. You know, I'm sleeping better, I have more energy. And in my approach, as long as you're in that zone where functionally you're better and you don't feel that you've backslid, and that's where some of the uncertainty comes in, then I think it's reasonable to go forward without a retitration sleep study or a confirmatory sleep study. If you feel uncertain or feel that something may have changed but you're not really certain, the only way to really know is to do a sleep study and do capnography. One of the things in the group that I'm part of that we're hoping to do is to be able to look at, instead of doing come in the hospital and get hooked up with EEG leads and a bunch of other things and trying to sleep with that, distill it down to the most important factor, which is carbon dioxide, and do home capnography. There's some challenges to doing that, both in terms of getting quality data and the price of the equipment, but it's something that I think would be a more reasonable approach, because it allows you obviously to see what a normal night would be in a bed at home.
I'm not clamoring to go in for more sleep studies, for sure.
I feel for parents, it's cruel and unusual punishment to have to accompany your child and sleep in an uncomfortable bed. We probably all been through it, so I won't...
We know.
I think you have one quick question. Question here. Please go.
Well, I just had
two questions.
really, okay, hold on. Okay, go.
I had just a quick comment on the DAXIS, and you had mentioned whether insurance covers it or not. Our sons have had it, the youngest every year and the other one every other year at Mayo, and every year it's a problem with insurance and it's always a coding issue. So always just follow up on it, just as a point of, they label it one thing, but if you call your insurance and call the clinic, they need to label it the proper way, and often it is covered.
Do you do it for the muscle fat ratio, or do you do it for bones?
I can't remember what we've talked about. I know we've seen an endocrinologist, and he kind of looks at it as...
Can you give her the mic?
Oh, yeah. We do it, our endocrinologist looks at it and our neurologist, and they look at it in the, I'm trying to think of all the different things he looks at.
Typically, if endocrinology is doing it, it's looking at bone health. So we do it for both purposes because it helps two of us out of our whole team help make an educated decision on how to move forward. So it's one of those, it gives you, we have to specifically ask for the body composition to be included in the report because radiology does all that. So it gives us more information than some of the other methods. So one test is giving multiple providers the information that helps us make an educated decision.
Okay. Two quick things. We were told to start our son on vitamin D and calcium, but then when we got the blood test back, he was in total normal limits for everything. So no need to add if he's good? Okay. And then the next question, maybe for anyone else or for you guys, just general feedback, stomach aches. I've heard gastroparesis, is that what it's called? I've seen that a couple times in the Facebook page. Nobody's ever said that about him. But at times he does complain about his stomach hurting. It's often after he eats, or sometimes it's in the morning. I haven't noticed it as much in the morning since we started BiPAP, but it still happens sometimes. So just general thoughts on that.
It's like yesterday in our talk, Dr. Call would have been the best one to answer that, the GI doctor from Cincinnati. But there's a whole bunch of different things that can cause. Is he G-tube fed or is it all oral? So it's all oral. It could be various things. It could just be too much at one time. If he's on BiPAP, he said that can also influence it with distension of the stomach.
Yeah, I'm just gonna follow up to Tara. We've been having morning stomach aches with Lily, and it seems to be the pressures. Her pressures needed to be adjusted because she was getting too much air in her stomach. So it was just morning stomach aches. For us, it was adjusting her pressures on her BiPAP, and then that resolved the morning stomach ache.
Okay.
Can I make one general comment before we close? There is a mention of not having an orthopedic surgeon. As I mentioned, I'm not one, but I work with a number of them. And we talked about scoliosis, and really the more appropriate term would be chest wall and spine deformity. Scoliosis is a side-to-side curve. There are also two other curves. There's kyphosis, which is where you tip forward, and lordosis, which is where your shoulders are back and you flex back much more than normal, and that seems to be the typical phenotype in SEPN1. And so the question, if you're thinking of doing a spinal intervention, is what are you treating and what's going to get better? As I mentioned yesterday, I don't think lung function is something that should be used as an outcome measure to demonstrate improvement, but I think a more subjective thing like work of breathing can be tracked. How fast you breathe when you do mild exertion, perhaps going upstairs. The other thing that you can get if you have severe lordosis, back arching, is that the distance between the sternum, the breastbone, and the spine can narrow. In more severe situations, not specific to SEPN1, but in other patients that have lordosis, the trachea can get compressed. And the way that would present is that if you're coughing and clearing mucus, the trachea can narrow and it can be difficult to clear properly, or you can actually have difficulty breathing, just a general sense of something sort of blocking the airway. And if your child has anything like that, the way that we would evaluate it would be to do a CT scan and see if there's actually compression. And if that were the case, then that to me would be a clear indication to intervene.
Okay, so well, thank you very much. Thank our panelists. It's been really great to have you guys here. Two last thoughts. First, a favor to ask to help with the research to allow us to communicate as researchers with each other about you guys is that there's a tool called a GUID, a Global Unique Identifier, which is an anonymous number that we generate using your name, date of birth, and place of birth. And if two investigators do this independently, because you're enrolled in two studies, then they know that they're talking about the same person without having to say that person's name or reveal the identity. So it's a way to protect your personal information. So for everybody who's enrolled in my lab study, if we don't already have it, could you stop and before leaving the room, just tell me your child's middle name and the city where they were born, where the hospital was. These are just the two missing pieces of information. The other thing I wanted to let you know, we have a very generous anonymous donor to my lab who about a little less than a year ago made a gift of $5 million over 5 years, specifically to support research on selenoprotein and this type of work. And it's really made a tremendous transformative impact on the work that my lab is doing. Although it's used at our hospital, it's indirectly supporting some of our collaborators and allowing us to do things with them that we couldn't otherwise do. So they wanted you guys as a community to know that, to hopefully give you some hope. That gives us a really good basis to do research in our group. And I think that together in partnership with the community, with you guys being involved in terms of participating, providing your information, sharing it not just with us, but with the other researchers around the world, with clinicians, we can hopefully build steam and we can push forward to some useful treatments sooner than we would otherwise. So if anybody wants to provide any feedback, you can do that through me. I'll pass it on to the donor, or if not, just at least wanted you guys to know that. And so thank you all for your tremendous support to the clinicians, the other researchers who aren't here, unfortunately, and Ferraro Esposito had to go home. They're part of our community. Just know that we're all working together on the same team. So thank you.